morning, my dear students. Today's topic of discussion is lipid lowering drugs. So where are we concentrating on this matter related to hypertension, atherosclerosis, myocardial infarction, and all other related matters which are actually responsible for sudden death. Lipid is an essential component for the building up of your cell, and it's not only that, cholesterol is also an important component of cell. Without cholesterol, it is extremely difficult for anyone to survive. But we all have to understand that these things, the key players, must be there in your body in a proper proportion. So let us start with a clinical case study where a person aged 42 years and having known type 2 diabetes appear for a medical consultation for chest discomfort and dyspnea. On exertion, he is suspected of a likely event of myocardial infarction because of his family history of myocardial infarction events in his fathers and siblings, one of whom died probably due to myocardial infarction at a young age. He is obese, weighing around 90 kg with minimal physical activity. His work does not require much of physical activity. Now, once the lipid profile is seen, we have monitored that its total cholesterol is coming around 340 milligram per dl. Triglyceride is 184 milligram per dl, whereas HDL is less than its normal amount, it is around 23 milligram per dl. Now, in this condition, how will you assess this case? What are the possible therapeutic approaches you consider fit for the person, and what are going to be the benefits that could be achieved with multiple strategies in this case? And you may add another point with this, that patient is probably having HbA1c level 8.4%, which is suggesting that patient is having definite type 2 uncontrolled diabetes mellitus, and fasting blood glucose of around 210 milligram per dl. So to find out the answer, let us go back to the physiology of lipid metabolism to understand how and why these players like cholesterol, triacylglycerol, and the phospholipids are important in the maintenance of lipid metabolism, or as a whole our total cholesterol balance, body cholesterol balance in a human being. So what are lipoproteins? Lipoproteins are protein-lipid complexes. Now in the structure we are seeing that there are some lipids which are bound to other molecules. Combination results in a structure. These are basically a complex lipid. The cholesterol is there. This is the protein, and the phospholipid is this one. So all these things are helping to form a proper structure of lipoprotein. Now cholesterol, triglyceride, and phospholipids are transported in plasma and other fluids in lipoprotein particles. Lipoproteins are macromolecular aggregates that contain lipids and proteins known as apolipoproteins or apoproteins. The lipids present in lipoproteins are free and esterified cholesterol, triglyceride, and phospholipids. Apoproteins are important since they provide structural stability to the lipoproteins, and they are also acting as ligands in lipoprotein receptor interaction. In the lipoprotein molecule, the core consists of hydrophobic cholesterol ester and triglyceride. So inside is basically the hydrophobic one, that is containing cholesterol esters and triglyceride, which we can also show in the following pictures. Water soluble components, namely apoproteins, phospholipids, unesterified cholesterol, are present in the periphery, that means in the surface. So in the surface you can see these things are there, the apoproteins, the phospholipids, and unesterified cholesterols. As a general rule, larger, less dense lipoproteins have a greater percentage composition of lipids. So let us go back to the this slide first, and then we will switch over to the next one, next slide. And here we are seeing the key players, as I said, the triacylglycerol or triglycerides, the phospholipids, and cholesterol esters. These cholesterol esters are of two types, the unesterified cholesterol as well as the esterified cholesterol. Now, these apolipoproteins are also playing the role of the key players, and this is basically the principal route by which the dietary fat is transported, and this basically these players are coming into the picture when we are going to describe the exogenous pathway. There are some apolipoproteins of chylomicrons which include ApoA1, which is present in the liver and small intestine. They are activator of LCAT, that means lecithin cholesterol acetyl transferase. ApoA2, which is also present in the liver, is structural and inhibitor of hepatic lipase. ApoA4, which is present in the small intestine, whereas ApoA5 present in the liver. But ApoA5 is basically related to the regulation of triglycerides, whereas ApoB48 is specifically present in the small intestine, is structural and synthesis of chylomicrons. It is derived from ApoB100 mRNA following specific mRNA editing, whereas ApoB100 is present in the liver, is structural, and is basically responsible for the synthesis of VLDL, that is very low density lipoprotein, which is basically a ligand for LDL receptor. Whereas ApoE is present in liver, macrophage, and brain. It is ligand for ApoE receptor, and it helps in the mobilization of cellular cholesterol. So again, ApoC are of various types. ApoC1 is present in the liver, 2 is also present in the liver, whereas 3 is present in the same site. They are all, especially 2 and 3, are the inhibitor of lipoprotein lipase enzyme, whereas the activator of LCAT is ApoC1. So this is basically the structure of the hydrophobic amino acid. Here you see the lipoprotein surface, as I described before, the hydrophobic and the hydrophilic sides. So the core is consists of hydrophobic cholesterol esters and triglycerides, whereas the surface, that is the water soluble compounds, apoproteins, phospholipid, unesterified cholesterol, are present in the surface, that is in the periphery. As a general rule, larger, less dense lipoproteins have a greater percentage composition of lipids, whereas chylomicron is basically the largest and the least dense lipoprotein subclass, whereas HDL or high density lipoprotein are the smallest lipoproteins containing the lowest lipid content and highest proportion of protein. So from this structure we can see the size of chylomicrons, the VLDLs. You can see the structure of LDL and HDL. And from this comparative study we can compare between the three, so that we also can understand that the size is not going with the density. High density ones are probably having the smallest structure. So when the lipoprotein metabolism takes place, it takes place in different ways. One is called the exogenous pathway, and this is basically also known as chylomicron pathway, happening from the dietary fat, whereas the endogenous pathway is basically the lipids synthesized by the liver. And HDL metabolism is the apolipoprotein transfer and ester transfer, also associated with reverse cholesterol transport. This is basically related to HDL metabolism. So basically these three metabolisms in a balance are maintaining the concentration of different lipoproteins, the concentration of different lipids in your blood or in the plasma, and contributing important aspects in lipoprotein metabolism. So the first transport pathway is the exogenous pathway, and that is mediated via chylomicron. And this chylomicron is coming from dietary fat or cholesterol. These are the largest one, which I have shown in the previous slide, and the least dense lipoproteins, and these are formed in the intestine. Their major role is to transport dietary fat, triglyceride, unesterified cholesterol, cholesterol esters to the adipose tissue, muscle and liver. Triglycerides of chylomicrons are removed by hydrolysis mediated by lipoprotein lipase. This pathway is also shared by very low density lipoprotein, resulting in the formation of free fatty acids and glycerol. Chylomicron remnants continue to circulate and are eventually removed by specific hepatic receptors. This is the principal route by which dietary fat is transported, and this pathway is called the exogenous pathway. And here you see the different apolipoproteins which are showing their predominant role are ApoB, ApoE, and there are some different ApoA1, ApoA4, which is derived from intestinal epithelium. There are some C1, C2, C3, and which are all derived from high density lipoprotein. So this is the exogenous pathway, and here you see the role of lipoprotein lipase, which is basically responsible for converting chylomicron to chylomicron remnants. From there to by the same enzyme it is converting to coming to the liver and taken up by the receptors, and some of the free fatty acids are, as I said, that they are taken up in the adipose tissue, few are in the muscles, and from liver the one which is going out, contributing in the metabolism is the very low density lipoprotein. This VLDL, this is synthesized by the liver in response to triglyceride production and provide a means for the transport of triglycerides to the peripheral tissues. Now VLDL particles are around 40 to 100 nanometer in diameter, contain triglyceride as a principal core lipid, ApoB100, ApoE and ApoC. C1, C2 and C3 are the apolipoprotein of VLDL. In contrast to chylomicrons, triglycerides in VLDL are obtained from fatty acids synthesized from the liver. So that is the structure of VLDL, and here you see the surface monolayer is phospholipid and free cholesterol proteins. This is the hydrophobic core, the triglyceride and cholesterol esters, whereas this is the ApoE receptor. This one is ApoB100 receptors, which are present in the structure of VLDL. Now, in VLDL metabolism, ApoCs and ApoEs and cholesterol esters are acquired from HDL in the circulation. So, the thing which we have to remember that VLDL triglycerides are hydrolyzed by lipoprotein lipase. They are yielding free fatty acids for storage in adipose tissues and for oxidations in tissues such as cardiac and skeletal muscles. As mentioned, triglycerides of VLDL and chylomicron share the same pathway for hydrolysis by lipoprotein lipase. In the process of hydrolysis, VLDL is depleted of triglycerides with the formation of VLDL remnants, and these are IDL, that is called intermediate density lipoproteins. Some of the VLDL undergo endocytosis directly by the liver, and remainder is converted to LDL. So VLDL, part of VLDL is converted to LDL. These steps form the basis for endogenous pathway of transport of plasma lipids. Thus, as the triglyceride level decrease, there is a corresponding increase in the level of LDL levels, and often it is referred as a beta shift, that is LDL is a beta lipoprotein. And cholesterol is mainly present as cholesterol ester. Free fatty acids are carried mainly by serum albumin, not lipoproteins. Now here you see the free fatty acid transport. ApoC2 activates lipoprotein lipase, which catalyzes the hydrolysis of triglyceride, and then this free fatty acids are forming a complex with albumin and is carried to the adipose tissues and in the liver, also in the muscle. So fatty acids are carried with albumin. They are not lipoproteins. A part of VLDL is converted to LDL, and as I mentioned before that a part is initially converted to IDL and then to LDL. These LDL particles are formed as a result of catabolism of IDL in the hepatocytes, and in LDL particles are almost 2% of the size of VLDL particles and 0.02% of the volume of a chylomicron LDL particles basically contain 50 to 60% of the cholesterol and less than 10% of triglycerides. So it accounts for higher plasma concentrations when compared to VLDL and IDL. The LDL surface protein is ApoB100, the only lipoprotein of LDL. So that probably we can show you. This is the one, ApoB100 is the only lipoprotein of LDL and is recognized by LDL receptors located in the pits of the walls in the hepatocytes. And the LDL particles bind with that, and their hepatic receptors are endocytosed, followed by incorporation of LDL particles into the lysosomes and separation from the receptor. This is the mechanism of clearance of LDL particles by hepatocytes. Hydrolysis of cholesterol esters from LDL, it yields free cholesterol for the synthesis of the cell membrane, and normally about 70% of LDL is removed from plasma by hepatocytes. Further elimination of the cholesterol occurs by secretion in bile and by conversion to bile acids. So the one which I mentioned is being shown here. Here you see the VLDL. LDL is removed by ApoB100 receptors, which are mainly expressed in the liver. Here you see the VLDL, the ApoB100 receptor. Characteristic of LDL is the VLDL lipolysis done by lipoprotein lipase, the VLDL remnant conversion, and then it is ultimately converted to LDL, and these LDL receptors are taken up here by the liver. The hepatic lipase is the enzyme which is responsible for conversion. So this is basically the way by which the LDL uptake is happening in the tissues. There are different fates of low density lipoproteins. Is the uptake by liver, it is around 75%. Uptake by extrahepatic tissues, it's around 25%. Receptor mediated 2 by 3, whereas it's happening in the liver, its uptake is around 3/4 in the liver, and non-receptor mediated uptake is around 1/4 in the liver, whereas extrahepatically it is 1/3 of LDL is undergoing uptake via non-receptor mediated pathway. Defects in the LDL receptor leads to familial hypercholesterolemia, and this basically a kind of disease. Normally the different types of hypercholesterolemia can be classified into two types, primary and secondary. Secondary is probably due to some secondary reasons which is leading to hypercholesterolemia, while a primary one is mostly due to some genetic factors, and there are 5 types of primary hypercholesterolemia existing in the clinical practice. Whereas if you look at the mechanism of this HDL uptake, you will see that high density lipoproteins are synthesized in the liver, and from here this in the intestines and circulate as a fragment of chylomicron and VLDL during lipolysis. So from intestine and liver it is synthesized and circulate in the plasma during lipolysis. It acquires cholesterol from the peripheral tissues and thereby offloading the burden of the cells and maintaining the cell cholesterol homeostasis. HDL is basically the major vehicle for transport of cholesterol from peripheral tissues including macrophage and endothelial cells to the liver. So that is the most important thing, and that is basically helping the excretion of these lipoproteins. The predominant apoproteins on the surface of HDL are ApoA1 and ApoA2, which is not shown here, but these are the two things which are mostly present here, and the synthesis of which is required for normal production of HDL. The transfer of free cholesterol from cell membrane to HDL is facilitated by a membrane transport ABCA1. Thus, HDL scavenge cholesterol from different peripheral sites and transport the same to the liver and thereby reduce plasma cholesterol levels. Increased number of circulating HDL particles are associated with less coronary and carotid atherosclerosis, and they are decreasing coronary events like ischemia, angina, infarction, unstable angina, even stroke, cerebrovascular accidents, and death rate. Coronary events are inversely proportional to HDL level. So higher the HDL level, it is better for the person. HDL particles improve endothelial function, reduce oxidation of LDL particles, and reduce cellular damage caused by oxidized LDL. And they are characterized of major classes of lipoproteins in human plasma and summarized in different clinical textbooks. The nascent HDL is produced by liver and intestine. That is the lipid pore ApoA1. So this is basically the cholesterol metabolism. The cholesterol balance is maintained via different ways. There is a dietary cholesterol which is contributing around 400 milligram approximately, varying from 1 to 1000 milligram per day, out of which 30 to 75% is absorbed. There is a part which is the normal rate of synthesis is varying from 600 to 1000 milligram de novo synthesis in the liver, with about 600 to 1200 milligrams are undergoing biliary secretion, and from there it is excreted in the stools. And taking into account the intestinal absorption of dietary cholesterol and the absorption of biliary cholesterol, total body cholesterol synthesis is around 0.8 gram per day after fecal loss. Total body cholesterol is estimated to be in excess of 125 gram, in which greater than 90% is in cell membrane. De novo synthesis is the major source of cholesterol, which mainly takes place in the liver and adrenal. The hepatic source contributing the major chunk of this synthesis of cholesterol starts with acetyl-CoA, which is converted to HMG-CoA. This is the one. This is the step. As you know, this from biochemistry, that the acetyl-CoA is the primary component, from where it is converted to HMG-CoA, that is 3-hydroxy 3-methyl butyryl coenzyme A, which in turn is converted to mevalonic acid, and the enzyme responsible for this conversion is called HMG-CoA rejectase, which is a rate limiting step. Ultimately, in turn, it is converted to mevalonic acid, and from mevalonic acid via almost 20 steps, it is ultimately converted to cholesterol. So diet rich in saturated fat increase serum cholesterol mostly by down-regulating hepatic clearance, whereas a diet predominantly of unsaturated fat is generally associated with lowering cholesterol levels. The liver is the primary organ for cholesterol uptake and degradation. Most of the cholesterol, which is converted to bile acids, in turn is secreted into the intestine to emulsify ingested fats, and the bile acids are reabsorbed, they are undergo recycling, and cholesterol, which is required for the formation of the cell membrane, the cell growth, synthesis of steroids, bile acids, and for different metabolic functions, reduced cholesterol levels may result in decreased synthesis of steroid hormones, including sex hormones, and reduced body defense mechanisms. So, whenever we are coming into the clinical aspect of this, we are very much concerned about atherosclerosis, which may lead to different kinds of clinical problems. And this atherosclerosis is primarily an inflammatory response to a blood vessel injury, injury to the endothelial lining, specific as the entry and the congregation of monocytes and platelets. This is followed by active and passive transport of lipid particles into the subendothelial space. So here you see is endothelial permeability to lipoproteins and plasma mediated by NO and endothel, upregulation of leukocyte adhesion molecules, upregulation of endothelial adhesion molecules, and ultimately migration of leukocytes into the artery. Now these monocytes are converted to macrophages, the phagocytes in phagocytes, the oxidized LDL cholesterol and transformed into foam cells, that is fatty streaks, and the platelet adherence occurs. The foam cell formation is mostly mediated by LDL, TNF alpha, IL-1 and MCSF. And before the phagocytes perish, they secrete multiple growth factors that serve as a principal mitogens for connective tissue cells such as fibroblasts and smooth muscle cells. Collagen is another principal contributor to atherosclerotic plaque, and its production leads to the formation of hard fibrous plaques. In response to increased plaque volume, arterial remodeling of the blood vessels this arterial remodeling occurs with simultaneous narrowing in the lumen. You just see the lumen is being narrowed, and simultaneous narrowing of the lumen of the blood vessel is responsible for most of the things. It leads to advanced and complicated lesions, and later on it may lead to formation of unstable fibrous plaque and ultimately the rupture of that one. So normally coronary arteries can dilate in response to ischemia, facilitating delivery of the oxygen to the myocardium. This process is mediated by nitric oxide acting on the smooth muscle cells on the arterial media. In the presence of lipoprotein plaques, this function of arterial dilatation is impaired, reducing the level of atherogenic lipoproteins and inhibiting their oxidation, restores endothelial function and reduces coronary events and strokes. It relieves symptoms, it prevents new plaque formation, it reduces rate of progression of atherosclerosis and can even induces regression with aggressive lipid lowering therapy. Though the reduction of LDL and triglyceride levels is having paramount importance in preventing atherosclerotic changes, it is the rise of HDL levels that contributes to the ultimate benefit of enhancing the endothelial function and removing cholesterol from the cells and lipids. So, it's always as a clinician, one has to see at the level of HDL while looking at the total amount or the volume of cholesterol. So this is the way the LDL is basically entering, where they may be modified, undergoing oxidation, and these modified LDL are pro-inflammatory. This is the way this vessel lumen is being narrowed, and the foam cells are formed, and here you see it promotes HDL is promoting cholesterol in plaques. So lesser the LDL is good for the patient, more the HDL it is also better for the patients. So to summarize, atherosclerotic disease is basically commonest cause of death and disability in the industrial countries, a focal disease of the intima of large and medium-sized arteries. It's undergoing several stages: endothelial dysfunction, monocyte attachment, endothelial cells bind to LDL. Oxidatively modified LDL is taken up by macrophages. Having taken up oxidized LDL, these macrophages migrate subendothelially, atherosclerotic plaque formation, and ultimately leads to rupture of the plaque. So there are different types of diseases which may happen when the normal range of cholesterol is not well maintained, and it can be of the primary forms which are primarily genetically determined, It is of 5 types: type 1, type 2, type 3, type 4, and type 5. Out of this, type 1 is basically due to decreased lipoprotein lipase. Type 2 is having two varieties, 2A and 2B. 2A is mostly LDL receptor deficiency, whereas type 2B is decreased LDL receptor function. Type 3 is basically a defect in ApoE synthesis, whereas type 4 is mostly happened due to increase in the VLDL production and decreased elimination, whereas type 5 is increased VLDL production. Whereas secondary forms are basically the consequence of other conditions like diabetes mellitus, alcoholism, nephrotic syndrome, chronic renal failure, and administrations of other drugs which may promote hyperlipidemia. So, other than diet modifications, exercise, lifestyle modification, sometimes the thing is so happen that cholesterol level is such that one has to go for drug therapy or pharmacological therapy, where you have to use some lipid lowering drugs. The drug therapy to lower plasma lipids is only one approach to treatment and is used in addition to dietary management. The correction of other modifiable cardiovascular risk factors are mandatory to treat the patients in the holistic fashion. So here you see the different drugs acting at different sites. There are HMG-CoA reductase inhibitors, and they are called statins. And there are different statins. Most common ones which are used in the clinical practice are atorvastatin, rosuvastatin. Besides these, there are some pravastatin, amiostatin, and some other statins. And these are basically, as I said, HMG-CoA reductase inhibitors and reducing the LDL cholesterol level. Whereas the one which is preventing anion exchange, presume that those are cholesterol and cholestyramine, which are not used nowadays much due to hypercholesterolemia. But in some other conditions where the patient is having cholestatic jaundice, probably people are getting this kind of drugs. Nicotinic acid is one which is also playing a key role, but it's having a lot of side effects like hot flashes and a lot of other problems. Hence, the nicotinic acid is also losing its importance as a first line drug. Whereas the fibrates, which are primarily modifying the synthesis of triglycerides. So isolated triglyceride level is usually controlled with the fibrates, and the fibrates are phenofibrates, gemfibrozil, benzofibrate. Whereas there are some other drugs which can be combined with statins, and there are some newer drugs which have already started being marketed, will be discussed later after the discussion of these primary drugs. In the next slide, I will show you the name of the newer drugs. So these are the few newer drugs which are being used nowadays in the clinical practice, and out of these are Lipoproteins, which is a ApoB inhibitor, obviously not used as a first line drug. MTP inhibitor is lomitapide, and CETP inhibitor, that is cholesterol ester transferase inhibitor, is torcetrapib. So these are the newer drugs which are used nowadays with the primary ones as adjuvant drug, where we are seeing that cases are resistant to the primary ones, or rather the primary drugs are not capable of tackling the situation. Besides all these three, there are some other drugs like PCSK9 inhibitors, that is basically pro-protein convertase saticylin inhibitor, and that is uh, by blocking that particular uh, PCSK9, these drugs like alirocumab, evolocumab, they are basically blocking the availability of LDL receptor and is increased to remove LDL cholesterol and reduce its blood levels. The expression of LDL receptor and PCSK9 are dynamic processes that respond to serum concentration of LDL cholesterol. There is certain other preparations like omega-3 fatty acids which are present in different other products can be useful as these lipid lowering drugs. Beside this, there are some plant sterols like cetosterols, stanols. Those are also having some role in the treatment of hyperlipidemia. So this is the first lecture in context of the lipid lowering drugs. In the second lecture or the following lecture, we will discuss the drugs which basically are commonly used and with their indications, adverse drug reactions, and vivid description about their utility in clinical practice. Thank you so much for your patient hearing.